Hello, hello, hello. Good morning, good noon, good afternoon. Welcome to Friday's edition of a virtual morning report. We're Reza and Reza's on his way. He's on service right now, so a little behind. We're thrilled to have you join us today. And I, you know, clearly I'm here almost every day, and I love this space. I love learning with you all and growing with you all. Um, and as per usual, would love for a volunteer to present a case to us. So if you were here yesterday and listened to Kat's absolutely mesmeric round three of a case, we'd love for any of you to do the same. In the meantime, I would love for Vali to say hi and for her to tell you what she's doing today, which is no small feat. But Vali, do you want to say good morning?
Good morning, everyone. It's great to be back. I've been having a busy week, but I think today's going to be a busy VMR as well for me because I am doing teaching points and scribing. So really expect a great case and a better discussion as per usual. So I'm going to pass the mic to Laura that's going to be helping me briefly, but I'm sure she's going to contribute a lot.
Hi friends, I'm Laura. I'm a third-year medical student from Brazil, and I'm gonna help Vale today a little bit, and then I'll have to leave, but super excited for today's case as always.
Yeah, folks, the commitment and dedication for these folks is unreal. Sometimes it's just like it's unreal all the time, but it blows me away sometimes. Just to do both of those things at the same time is not easy at all. So please do not disappoint Vale and Laura. We're here to do both those things. So if you have a case, please volunteer to present it. I'll give the chat a minute or so to see who has a case, and we'll be right back. Drop dead silence in the chat. Hello, Ravi. Good morning. I see also VJ is also joining us. It's a desert island in terms of our case today. We're waiting for the plants and the flowers and the oceans and the rivers, and let the analogy continue to fall until it collapses into a desert again. Hello, VJ. I feel like I haven't seen you for a long time, my friend.
Hello, Ravi. I can volunteer to present a case if that's okay.
Really? No way. Before you do that, tell us where you've been and what you're up to.
I'm currently in my final year of internal medicine residency. I'm just preparing for the exams coming up in another 2 to 3 months.
Amazing. So what exams do you have to take in India?
So this is like the university exam. So at the end of 3 years, our residency is for 3 years after we finish our MBBS. So at the end of 3 years, we are supposed to take exam. It's mostly a written exam.
I see.
Yeah.
Wonderful. And what have you been doing anything outside of medicine recently that you want to update your VMR family? Or has it been all
nothing much?
Yeah.
All about exam, but currently I was posted in cardiology for about 1 month. So got to see a lot of interesting cases there.
Amazing. Is that a hint for what's coming our way?
No, this is completely different from cardiology. But this had a lot of teaching points for us when we managed the case. So I thought I'd just share it.
Wonderful. All right. Well, we're ready whenever you are. Take it away. And it's so great to see you again, Vijay. Thank you. I think you're muted, my friend. We're ready for your initial
Yeah,
outcome.
just a second. I'm just
Hey, no
trying to
worries.
get the
No worries at all. Take
data
your time.
this time.
Yeah, no worries at all. Oh, Ravi, thanks for checking. Yes, the store was crazy. San Francisco is um, not prepared to handle the amount of rain that we got, but thankfully things are okay. There was a lot of flooding in the areas around San Francisco, specifically the North Bay, but we're thankfully okay. Thank you for checking. I see VJ has a beaming smile on his face, which means he's ready. Take it away, my friend.
Yeah, yeah. So I'm presenting a case of a 28-year-old lady who comes to the chief complaints of generalized weakness since 1 week with history of high colored or cola colored urine since about 5 days and vomiting since 2 days. Uh,
Wonderful, VJ. That's a great place for us to reflect, I think. So you said generalized weakness, highly colored urine. Is that right?
yes, yes, high colored urine and general and vomiting since 2 days. This was her chief complaints. For this complaint, she was admitted in a hospital, and 2 days later, she developed in hospital. She developed a sudden episode of irrelevant talk with involuntary movements of all four limbs, and was shifted to the ICU for further management. I think I'll stop the stem here.
All right, marvelous. That is a great place, my friend. So, I think if we try to follow in your footsteps, I imagine that the following sequence of events happen. You first heard weakness, then you heard urinary issues and vomiting issues, and then you moved on to realize her what appears to be a neurological consequence. And if you're in the world of weakness and you're just meeting somebody, the first thing that you have to decide is there a neuromuscular cause of the word weakness, or is the patient using the word weakness to convey what we medically encode as asthenia? And asthenia is what every medical trainee suffers from almost every day, which is the sense of fatigue. And often we use fatigue and weakness interchangeably. That analysis comes with the caveat. The caveat is that patients can feel asthenic from a neurological cause of weakness. So you have to be careful. Those two things are not mutually exclusive. But what are your clues that a patient has asthenia? Asthenia is a sensation of weakness that is predominantly present at rest. Most patients with neurological causes of weakness have a dynamic cause of weakness, meaning that when I do something, I feel weak, rather than the predominance of weakness at rest. So here, just the fact that the patient is reporting generalized weakness at rest, presumably, it really prioritizes asthenia as the initial cause. But then that has to be tempered with the fact that this patient literally develops involuntary movements in her limbs afterwards, beginning the questioning of whether she has asthenia at all or asthenia alone. And right now, I think the case for asthenia is strong enough with the patient presenting with weakness, but it's hard to argue with a neurological presentation that develops afterwards. So I suspect that we're dealing with a case that features both asthenia, the sense of fatigue, but also a neurological complication. How does the presence of vomiting and dark urine help us? Dark urine in most patients is the fact that the urine is concentrated. And that is the most common cause. And that is a cause supported by the presence of a large amount of vomiting. When somebody's vomiting a lot, they're going to concentrate their urine and that urine is going to look dark. But here's the caveat. The caveat is that when patients have dark urine from it being concentrated, it doesn't usually stand out to them. So the fact that this patient is making note of her dark urine is a little bit unusual and should prompt us to at least take an initial step to say, could this be something else? Recognizing that the base rate in this circumstance is so overwhelmingly that it's concentrated urine. So how could the urine be colored? And the color can either come from something that the patient is bringing in or the patient herself is making. And common things that patients bring in is foods and medications. So beets are a notorious trigger, and medications like rifampin are a notorious trigger, and we'll wait to hear about them. But believe it or not, we can create color within our body, and that color usually comes from the heme pathway, usually the result of heme processing in the form of bilirubin, but also in the form of heme or myoglobin breakdown. So hemolysis, hematuria, and myoglobinuria are notorious causes. But you also have to step back and prioritize the porphyrin synthesis pathway, where porphyrins can also discolor urine. So I would say generalized weakness, asthenia, followed by neurological symptoms is probably a neurological cause. The dark urine is probably concentration issues, but you have to step back and think about alternative causes. I have to say, the case that you're presenting here is very evocative of a very specific diagnosis. Whenever somebody has the combination of dark urine, generalized weakness, and involuntary movements, you have to think about a perturbance along the porphyrin pathway. And the porphyrin pathway, practically speaking, is either perturbed genetically through acute intermittent porphyria or through acquired toxins such as lead toxicity. So I would never encourage you to think about rare diagnosis early on. But I think because it is potentially life-saving for this patient, you have to worry about acute intermittent porphyria here. And what could you do immediately? You could take the urine and study it under Wood's lamp. And if under Wood's lamp it fluoresces, that augments the case for a porphyrin within it. And you might have to give this patient acute therapy with IV glucose or with hemin pretty quickly. But we should remain humble and broad and explore all these leads in parallel. Why is she having involuntary movements? And we'll have an exam that will help us. Why is she having dark urine? A urinalysis will help us tremendously. And I would follow those two leads, but early on, when you hear urine changes and neuro changes, you have to think at perturbance along the porphyrin pathway, for which you might need to give IV glucose right away. All right, Vijay, back to you, my friend.
So there is no history of any abdominal pain or fever that the patient noticed. There's no history of rashes as well. Past medical history was not significant. She was not on any ongoing medications. Family history and social history was not remarkable. She denied any history of any addictions or any allergies. She was sexually active. Other than that, the past medical history, family history was not very contributory for her presentation. So on arrival, this was her vitals. Her BP was 120/82, pulse rate of 115. She was afebrile at presentation with the respiratory rate slightly tachypnic at 30 cycles per minute with a saturation of 95% on room air. General physical examination revealed marked pallor with a mild icterus and petechiae on the physical examination with cardiovascular, pulmonary and abdominal examination fairly normal with mild splenomegaly on abdominal examination. There is a lateral tongue bite on the, there's a right lateral tongue bite that is noticed in the hospital. Other than that, there is no focal neurological deficits that was noted clinically. Going to the basic labs, I think this will change the thinking process for us. Her hemoglobin was, I forgot to mention, she is an active vegetarian in the diet. Her hemoglobin was 5.2, HB 5.2, total count of 15,000, neutrophil 70%, lymphocyte 20%, platelet count of 10,000, reticulocyte count of 10% with an MCV of 74. Peripheral smear demonstrated a dimorphic anemia with a leukocytosis. It was negative for schistocytes. The serum haptoglobulin levels were reduced with LDH of 2088. Peripheral smear negative for malaria. Initial viral serologies were negative for HIV, HBsAg, and hepatitis C. I think I'll stop at this.
Amazing, Vijay. You've really kept me on edge here. I want to ask you one question. Do you have the liver enzymes and the bilirubin handy, or do you want to stay?
Sure. I think I can give that as well. The bilirubin showed total bilirubin of 4.08 with an indirect bilirubin of 3.6. AST levels were 80, ALT was 42 with a normal alk-phos and GGT. Total protein and albumin being normal.
Oh, just so intriguing. You know, this case takes a rapid shift. And Vijay, your exam skills are superb here because what you noticed here changes the calculus immediately. No longer is it pertinent why this patient has generalized weakness. It doesn't matter because the lab abnormalities are so pertinent and each of them provides sufficient explanation to the generalized weakness. And I think our initial hunch is correct. We found a neurological disease clearly with the fact that the patient has a seizure as evidenced by the lateral tongue bite, which is very specific for a seizure. And we found reasons for asthenia because if your hemoglobin is 5 and your billy is 4, it's almost certainly asthenic. So the world that we're in is we have to find a systemic cause that also accounts for a neurological complication. And so the clues that we have for this systemic cause are plentiful. We have hematological perturbances that can be summarized as an anemia, a thrombocytopenia, and splenomegaly. So the world that we're in has to explain anemia, thrombocytopenia, and splenomegaly. And which one of those things can we further analyze? And I think the nature of the anemia here is very informative. Here, we don't know the time course of the anemia, but we know the mechanism. The reticulocyte count is elevated, markedly so, suggesting that the bone marrow is healthy and therefore implicating a peripheral destructive cause of the hemoglobin, which is diagnostic of a hemolytic anemia when you see that the LDH is high and when you see that the haptoglobin is low. Okay. So this anemia has a hemolytic component to it because we see that the indirect bilirubin is high, the LDH is high, and the haptoglobin is low. What is the caveat here? The caveat here is we also have a low MCV. And the low MCV can be explained by other things like lead toxicity, which came up in aliquot 1, thalassemia, and iron deficiency. Most commonly, it's iron deficiency, which begets the hypothesis that there's also a blood loss component to this anemia. That has to be tempered with the fact that a 28-year-old woman likely has menstrual blood loss and therefore anemia, microcytic anemia from that domain. So the most likely hypothesis is that, yes, you have to keep the thread of blood loss open because of the MCV, but the case here is this is a hemolytic anemia. But it's not just a hemolytic anemia. This is a hemolytic anemia with a concomitant thrombocytopenia. Now, how does that inform our workup? The presence of anemia and thrombocytopenia changes the landscape quite a bit, but not definitively. And I'm going to show you a way to approach it. So when you have both anemia and thrombocytopenia occurring together, this is the world that I would suggest you enter. You have to first be practical. Any cause of thrombocytopenia, especially to 10,000, can cause a blood loss anemia, but we've made a compelling argument that a blood loss anemia is not the only case, not the only cause here. we've actually made the argument that our anemia is hemolytic. And so we must first wonder, is the splenomegaly accounting for both? Does it cause both an anemia and thrombocytopenia? But the truth is a splenomegaly shouldn't cause a hemolytic anemia. So our priority is going to be looking for a microangiopathic hemolytic anemia, which is mitigated by the absence of schistocytes, an autoimmune hemolytic anemia, and thrombocytopenia, or an infection like malaria or babesia that can infect both. So the question here is, what is destroying red blood cells and what is destroying platelets? And the answer may lie in the environment, microangiopathic hemolytic anemia, on the membrane, autoimmune hemolytic anemia, or inside the cell. A negative malaria smear is very helpful, but it's not perfect in understanding the mechanism of the probability of malaria. So that you still have to entertain. What do we do with the splenomegaly? The splenomegaly, you have to interpret with caution, because it does usually take a little bit of time for the spleen to become big. And so you might say, hey, I'm not sure that the time course is as acute as this patient is suggesting with the fact that it's developed over 5 days. So we might have to say, hey, is this syndrome actually more chronic than what we think it is? And then what do we do with the seizures? Most patients with autoimmune hemolytic anemia and thrombocytopenia don't seize. So why is there a seizure at play? That might be because of a neurological focus for the hemolytic anemia and thrombocytopenia, which is a feature of falciparum malaria or cerebral malaria, or a feature of TTP, both of which are at play here. So I think, what would I do? I would repeat the smear to look for the scene of the crime again to make sure we didn't miss anything. I think a Coombs test is very, very helpful here and can put to bed the possibility of autoimmune hemolytic anemia. I think cerebral imaging may be informative, though if you understand the hemolytic anemia, you might understand everything in this case. All right, Vijay, back to you, my friend.
Yeah, it was wonderful, and a lot of things going in the chat as well. Brilliant discussions. So her Coombs test was negative, both direct and indirect was negative. Malarial smear was repeated, it was negative. Her INR was 1.2. Neuroimaging was normal. The MRI was normal. There is no enhancement, or the structural parenchyma was normal. Her ANA profile was negative. So in view of these and the other infectious workup for the altered sensorium and this presentation. So a leptospira was leptospira and a rickettsial panel, dengue and malaria were all negative. Repeat INR is 1.2. The INR is 1.2. And the initial EKG was not really contributory. It was just a normal sinus rhythm, and just radiograph was normal. So what was going on in our mind similarly, and her fasting lipid profile showed normal triglyceride and ferritin levels as well. So in this presentation, we were suspecting here there's a lot of tropical infection being very common. So we are not really sure there's an infectious process or inflammatory process going on. But in view of this ongoing hemolysis, basically it's more of non-autoimmune process. What clinched this diagnosis for us was repeat peripheral smear. Repeat peripheral smear showed plenty of histiocytes. And the bun and creat levels being normal with plenty of histiocytes. I think this makes it obvious at this point of time
Yeah, EJ, I think that's maybe we can stop there and analyze this case. And I
Yeah.
also see, I think I see the one and only Prof. Rez here, and I think, Rez, do you want me to summarize where we're at, or do you feel like you have a good grasp of
No, I think I came right where we're about to make a diagnosis, and I was able to follow the whiteboard. Hello,
Awesome.
everyone. Nice to see all of you. And this is what a phenomenal case, VJ. And sorry, I'm a bit late here. And I think listening to Robbie discuss the previous aliquot, that combination of thrombocytopenia, anemia, and not just any anemia, but hemolytic anemia, really made us worried about a microangiopathic process. And we have two really good schemas on our website. One is for thrombocytopenia that Anand Patel helped create. And it's actually quite marvelous, because once you get to that hemolytic positive, and if you have schistocytes without renal insufficiency, in this degree of and neurologic manifestations, you are at TTP. So this is really important, because if you miss this diagnosis of TTP, it can result in death. It can result in death. And they'll teach you the pentat in medical school, but if you wait for the pentat, maybe it's too late. At UCSF, they use a triad, and that triad is elevated LDH, thrombocytopenia, and schistocytes. If you have these three findings, you need to talk to a hematologist. So this patient, I would be calling hematology to start plasma exchange. Additionally, I would send an Adams TS13, which will take some time to come back. And then the question becomes, is there a trigger, or is it idiopathic? And those triggers include HIV, lupus. The ANA being negative makes lupus unlikely, but we should send an HIV if we haven't yet. And then the other causes include medications like cyclosporin, patients who've had transplant. And if all of these are negative, that Adams TS13, we expect it to be low, then we need to check the antibody to Adams TS13, the IgG. Because there are congenital causes of TTP, one was in the New England Journal of Medicine that Gurpreet Dhaliwal discussed, and that was titled Upshaw-Shulman syndrome, congenital TTP. So I'll give the mic back to Robbie, but where I am right now is that the patient knee is not in a doxy deficient state, Kushal, but in a plasma exchange deficient state. Needs Adams TS13 levels, needs the antibody sent, and we need an HIV testing.
Prof. Rez, anyone listening to this knows that was a hematologist dissection of hemolytic anemia and TTP. I don't know if you got this part of the case, Rez. The initial smear was no schistocytes, which I think illustrates just how humbling diagnostic testing can be. And I know we made this point on RLR over and over again, but I will tell you something really, really important. If it's not in the name, the smear can be negative. So of all the causes of hemolysis you can think about, if it's not in the name, the smear can be negative. So sickle cell anemia, it's in the name. You're going to see sickle cells no matter what. Hereditary spherocytosis, it's in the name. You're going to see spherocytes no matter what, basically. But anything else short of that, you may not see the finding you're expecting to see. And in DIC, for example, the smear is only positive for schistocytes in 50% of the time. And the additional piece of flexibility that I will help you encode in your illness script for TTP is not this like hyper acute thing that we think it is. TTP can have a smoldering course. It can actually be a chronic disease for people where the first clue that they're flaring is a drop in their Adams TS13 before they even develop schistocytes. So repeat testing, if your pre-test probability is increasing, repeat testing of the smear is almost always indicated unless the name is in the diagnosis, hereditary spherocytosis or sickle cell. And Prof. Rez makes this point by making the analogy to troponin and to CK, which I will butcher. So I'll actually pass the mic to you to remind us of that very, very important lesson. Because I think if we didn't repeat the smear here, we would have missed the diagnosis.
Yeah, absolutely. I'm not, I don't know exactly what you're referring to, Robbie. I know.
Cycle that repeat. Okay, so I'll try to summarize. There are many instances where the UA can be falsely negative. So repeating the UA. So trending the UA and trending the opponent is a point that you frequently make. I don't know if I jogged your memory or, yeah.
No. You absolutely nailed it, and I'm very interested to see what happened to this patient. Yeah, VJ.
Yeah, so like someone had mentioned the pregnancy, her urine pregnancy test was negative. So because of this high degree of the neurological presentation and when she came to us, she was like completely stable. It was just some component of asthenia when she came in. And the sudden deterioration and the profile made us suspect this very high. So meanwhile, we had started her on plasma exchange in view of this presentation because of a lot of cystocytes. Um, Her plasmic score initially was 6 with an ADAM TS13 activity came as 0.7% with antibody levels of 68%. But sadly, she had a refractory status epilepticus and was intubated one. Second thing is she developed an hospital-acquired infection. It was an ESBL Klebsiella that she developed. Third thing was even after multiple cycles of plasma exchange and steroids, her disease was refractory. So we had to give a cycle of rituximab as well. But with all of this, with two immunomodulators, immunosuppressants, and plasma exchange, she didn't really make it. Like she required multiple transfusions, which really didn't respond much. So that was when she had a STOMI course added to the sepsis component as well. She didn't make it through. But what was humbling for us was the suspicion that of repeating the smear. I think that is what brought us to the diagnosis. And one thing that I read about further, what my professors told me was the percentage of cystocytes really can help in the prognosis as well. So whenever it's like more than 1%, they become really significant. And if it is more than 8%, they indicate an impending hemodynamic collapse. I couldn't find literature supporting it much, but that's what was told to me. So that was our course. There's a lot of learning and reflections on that, but I just had to lose the patient.
VJ, sad outcome for sure, very sad. And it just tells you how devastating this disease can be. And I think it's just so important that you bring such a case to the community so that we all can take the important pearl of repeating studies and not putting too much value on the first triage of those studies. I think that's such a valuable lesson. And yeah, it's very unfortunate. And if to speak a little bit about the pathophysiology here, basically, if you have antibodies to Adams TS13, now you have these large multimers of von Willebrand, and this leads to in situ thrombosis of the vessels, like the small vessels. So as the red blood cells come through, they're not going through a patent vessel anymore. It's getting squashed in between the thromboses. And that's where you get the helmet cells and the schistocytes. And the same thing with the platelets. So it all comes down to physiology as to why all this makes sense is you have deficiency of Adams TS13, leading to large von Willebrand, leading to in situ thrombosis, leading to shearing of both red blood cells and platelets. But thank you for sharing this. I'll pass the mic to Robbie to see what his reflections are before we get the teaching points.
VJ, every single time you present, I think we've always been humbled. Truly, thank you so much for taking this case. And I think the outcome is devastating. And I think All that we can really do about it is to reflect on that on a personal level, but then also be able to try to do our best to mitigate a similar outcome in the future. And I think this is probably one of the most effective things that you could do for that, quite honestly. I think just to step back and say, to answer the point that Reza brought up about are there any familial implications here? And the congenital form of TTP, what you expect to find is a super low ADAMS TS13 level and a negative antibody screen. So the deficiency would be absent. Believe it or not, it's actually complicated. That's what you expect to find, but that's not confirmatory of a congenital disease, because you can have non-antibody mediated acquired TTP, and it's thought to be that the destruction that is acquired is complement mediated. And so distinguishing between antibody negative ADAMS TS13 deficiency has a DDX, and that DDX is congenital disease versus complement mediated. And sorting that out is probably best left to the experts, but know that the implications are, if you have a negative antibody screen, you have to think practically, just for you, to think, what about the patient's family members? And so here the antibody screen being positive at least doesn't put that, does not leave that, does not put that on our table. And thankfully we can say that her family members are at no higher risk than anyone else's. But Vijay, thank you again for a marvelous case, and thank you to, I saw Vale and Gabrielle tag teaming the teaching points. So Gabrielle, if you're up, take it away. But if I'm wrong and Vale is doing it, we'll pass the mic to either of you.
And Ravi, one last interjection before we pass the mic for the teaching point. I think the neurologic, presentation of it is just so unique. And like when you go down that route of thrombocytopenia and anemia, it's just hard to explain it by many other causes. So that may have been a smoking gun that this was, like you mentioned during your discussion.
Hi friends, how are you? So for the teaching points, at first we were approaching this patient with generalized weakness plus color urine. So at first, for studying the weakness, we have to wonder if this is true weakness versus an asthenia process. But we also have to keep in mind that these processes are not exclusive, meaning a patient with asthenia can also have a true weakness and vice versa. So what clues can help us differentiate between the two? First, if it's a dynamic weakness, meaning that the patient reports more weakness after doing activities that points towards an asthenia process, rather than if it's weakness at rest, then we have to think about a true weakness process. But then also one of the main shift complaints was dark urine. So how can this sign can help us to establish a diagnosis? So first, for a dark urine, the first cause is a concentrated urine. But if it's one of the patient's main complaint, we have to wonder that this could be explained by alternative causes. Also, this patient moving forward in the history of present illness, the patient reports neuro symptoms such as involuntary movements in all the 4 limbs. So linking that with the dark color urine, that could be explained by an acute intermittent porphyria. And one rapid diagnosis test that can establish a diagnosis is a positive fluorescent test in a wound lamp observation. So for this condition, the classical clinical presentation, usually the patients come to the ED because of unexplained abdominal pain and new onset of neuroplastic gastric symptoms. And also a poor wine color urine can be present. Moving forward with a physical exam and also some labs, we were completing the puzzle. So in the physical exam, we noticed a lateral thrombite, that this could be explained by a seizure. And also the labs were compatible with a hemolytic anemia picture. Also the MCV was low. So these two signs could be explained by 2 different mechanisms. Also the labs were suggestive of thrombocytopenia. So for a hemolytic anemia picture plus thrombocytopenia, we can establish some differential diagnosis, such as splenomegaly, microangiopathic hemolytic anemia, Evans syndrome, and some infections such as malaria and Bartonella. 2 tests that can help us to narrow our differential and that are rapid and very useful in a clinical setting are the cum sense and the peripheral smear. But it was surprising that these two tests were negative. So if our pre-test possibility is very high, we have to repeat the testing. And this is very important because some morbid conditions such as the TTP must be diagnosed very early to do a corrective treatment. And we also could move forward in thinking different hypotheses. So for finishing the puzzle, we repeated a testing and it comes positive, and also linking that with a thrombocytopenia plus hemolytic anemia plus neuro symptoms. Those conditions can be explained by a thrombotic thrombocytopenic purpura. And also we have to remember that we as medical students, the penta that is classically present on the boards is actually rarely present. So if we see a patient with a hemolytic anemia picture plus schistocytes plus thrombocytopenia, then we have to think very clearly in thrombotic thrombocytopenic purpura. Thank you so much for this case. I learned a lot.
Amazing recap, my dear friend. Thank you for joining us, and we'll hope to see you all tomorrow. It's a very, very special session organized by the one and only Rafa Medina, along with many others on the global IMG team. It's by Dr. Adi, who you may know from Twitter, who has an incredibly powerful journey as an international medical graduate. He's also absolutely hilarious. If you don't follow him on Twitter, you should. And so I highly, highly recommend you join us tomorrow at the same time we started today. Bye.